I'm Ben Ryman, and this is Behavior Speak. In this conversation, Kat Monlux delves into the complexities of diagnosing and treating individuals with Fragile X syndrome, exploring the nuances of behavioral diagnoses, the importance of randomized control trials and research, and the challenges of insurance coverage for interventions. Dr. Monlux discusses her research findings, the efficacy of interventions, and the financial and logistical hurdles faced in the field of behavior analysis. She also touches on future directions for research and the need for broader accessibility to effective treatments. Welcome, Kat.
Hello. Thank you for having me.
Thanks for being here. Before we get started, I just want to acknowledge I'm producing this podcast in the land of the Homo, Kolkomox, Klehus, and Klaaman First Nations. So, Kat, tell me about yourself. Where'd you come from? What's your story?
Geez, that's a big question.
Give me the big answer.
Oh goodness. Okay. Well, I came from the Seattle area, and I'm back in the Seattle area, but I've been around the West Coast in the U.S. kind of generally throughout, I guess, my career. That's probably what we're talking about here. I moved down to Southern California, and that's where I went to college and got my master's and started getting into like behavior analysis more generally. And then I've kind of moved up and down the coast many times.
How'd you get into behavior analysis? Why'd you go there?
I kind of stumbled into that in my undergraduate. I just wanted a prestigious psychology internship, and I was at UC Davis, University of California, Davis in Northern California around Sacramento area. And there's a place called the Mind Institute there that works. Yeah, it was very lucky. That was my like internship option. So I totally just stumbled into it. It was, sounded like something to do. And as soon as I got into it, I was just, your entry level position is like babysitting like the siblings of the kids who come in for like interviews, and you get to film the assessments, but essentially you're a glorified babysitter. You're cleaning toys, you're just watching assessments essentially if you're lucky. And so I started watching some assessments, and I got interested. It seemed really interesting. And then I was also lucky enough to kind of get siphoned off into some research studies that I was working on. And so I started working on the Early Start Denver model as a study research assistant. And then I really liked it. Like I was able to like film things again, but they wouldn't let me do anything. So it was an office. So I went out and got like a year of ABA experience just working for a local agency. And then I was able to come back and be a therapist. And then I just keep finding ways to work with the population. So I was working with, the Mind Institute works just with autism and Fragile X.
Oh, okay.
Then later I came back to the Fragile X side, but I've kind of just been working with those kind of populations ever since. And so, but it was purely just stumbled into the internship and really liked it. And then they couldn't get rid of me.
Yeah, wow.
Ever since.
Right on, that's awesome. So where'd you do the master's then?
So then I moved down to Southern California to around LA area, and I got my master's from, it was Northridge, so Cal State Northridge.
Gotcha, cool. And then you went on to do a doctorate. Where'd you go for that?
And then my doctorate was very complicated. I worked as a behavior analyst for like a couple years, and then my first big job there was working at Stanford. I ended up working on that was the grant that I ended up using for my dissertation research. So I got a job working, essentially what my dissertation ended up being about, doing Fragile X caregiver training. And I started working there, loved it there, didn't really want to leave, but I had been talking to Oslo Met in Norway, just trying to figure out a way that I could go out there to do my dissertation, get my doctorate from that institution. And they had an option where if you kind of found your own funding source, which ended up being the grant I was already working on, you could go up there for, well, you had to pay for it, but you could go out there. If you could self-fund yourself, you could take the classes, and you obviously had to get accepted into the program and propose what you were going to do. And I did that. So I got all my research experience at Stanford, but then my doctorate's from Oslo Met in Norway.
Yeah, I want to know more about that place. So why'd you want to go to Norway besides Norway just being cool because it's Norway? Maybe that was it.
Well, Norway's cool because it's Norway, but also I was pretty interested in like a couple pieces. Like there was a professor who was visiting when I was at Northridge, Sigmund Eldevik, does some really cool meta-analyses. And so I liked the research that he was doing. And so I was asking him just broadly about, are there any openings at his institution? And he was telling me, it's free. Like a little bit that I was like, wait, what? Like school's free there? That's silly. Not all school, but the doctorate program's free, and it's free for anyone. So like citizens or just anyone who gets accepted in. So that was like just a note for me.
Yeah, for sure.
In the US it is not free, and I have quite the student debt even from my public school endeavors. So that was certainly something I was thinking about, but I didn't just go because it was free. That was just the main thing that I was okay, listening. But then I started going to like conferences, and I just realized like the conferences I was going to at the time, like, ABAI, they had a lot of like Norwegians presenting, and a lot of them were coming from the same institution. And they were doing really systematic research. Like I liked the meta-analyses they were doing. I know some people were doing joint attention research. And so they had like operant analyses that were really cool. Like everything was just so systematic and clear, and it's like, oh, and free. And so I was like just thinking more and more about the institution. Had never been there, don't speak Norwegian, don't have Norwegian family. There's no real ties on that end. It was just like, okay, like this seems interesting. I'll throw it out there. And especially they didn't have I didn't have to move anywhere if I got accepted. They do consolidated classes. And so I essentially just hoarded my vacation time and used that to fly out for kind of intense trips to Norway, where the classes would be about 2 weeks, like 9 to 3.
Gotcha.
And they're pretty intense, but they're really fun. And so you would read a bunch of articles, and then the next day you would have group presentations, and then you'd have to present on these different articles. And it was so intense. Doing that jet lag wasn't super ideal,
Yeah, for sure. But neat to just go to Norway too, I imagine.
Yeah, no, like the first couple of times I did it, I think backwards, where I like went out for the class first, and then I kind of like peeked around while I was out. You take the 10-hour flight out there, might as well do a little exploring. And then I started flipping around. I explored first, kind of got used to like the time change, and then did my class, and that was
I've heard that there's a lot of stuff going on in Norway, but I never know who's who and where they're from.
Yes. So there was Sigmund Eldevik. He's famous for like meta-analyses. My co-advisor was Per Hall, and he does joint attention research. That's why I was so interested in working with him. But he also does like some, animal work as well. And so he wouldn't let me see the rat lab when I was there. It wasn't set up, but I was like, let me see him. So Per's like amazing too, and like he has such a wealth of like historic knowledge. So
does Norway have like actual like ABA stuff for autism, or is it mostly like more research and like basic research, that kind of stuff?
Yeah, they definitely do. It seems more well they do it here, because it's like ABA isn't like just for autism there. And so like when I talk about that in the US, they're kind of like, okay, it doesn't need to just be for okay. Little story cat. And so they seem to keep it more like open, and just how like services are provided seem like better. Like it just seems like a much better quality of life. I mean, for everyone, but for people with autism, like in particular, like there's much more like training for jobs. Like that's a big deal out there, and they really do try to find like gainful employment. Like a lot of people do go to. They have really hard to pronounce words for these. I won't know the name for it, but they have like a type of home, but it's not like how we like the institutions and like at least I'm more familiar with like in the US where like
Group homes and whatever.
yeah, it's more like they have like a smaller apartment and like quality of life is a little bit more important to where like it is very much like this is your home and maybe like the apartments are really close together so that people come by and like make sure everything's good.
Yeah, I think they
But
call that like cluster housing here, but I know what you're talking about. I've seen a couple examples of that. That's cool. Yeah, that's awesome.
so it was really interesting to have like the international perspective, especially going through the courses there.
Hmm.
Because they had, at least for the doctorate program, they took they had Norwegians, of course, but then they had Swedish people, so they also kind of like, yeah, that's the same thing. They had the Scandinavians, but then I met people from Spain, I met people from Brazil, there's
Oh,
people
yeah.
from Russia, like US, there was a few of us, not too many though. It was just really international. So like when I talk about like what's going on in my country or like ABA there, like
Neat.
you just really you learn like more global perspectives, and so that was really cool.
That is really cool. You always encourage folks to sort of, get out of their hometown and look around. It's interesting that basically a lot of ABA in the US, they just never left home. They're just not aware
Yeah.
of sort of, A, maybe sometimes how good they've got it, but B, that maybe what they're doing isn't the only way,
Hmm.
way to do it. So, do you have a credential with the International Behavior Analysis Organization, the Qualified Applied Behavior Analysis Credentialing Board, the Behavior Analyst Certification Board, or would like a certificate of attendance for another organization? You can earn continuing education units by going to www.behaviorspeak.com, clicking on CEUs, and entering the 3 secret words. The first secret word is infant.
Yeah, and that's yeah. No, it's going to Norway, hearing about Norwegian experience, and just like we should do it like that. Like it's just not so tied to like insurance, which I
Yes,
mean they have their whole health systems completely different, but
right.
it's interesting. And then
Yes.
another, well, like why Sigmund Albrecht was doing like the meta-analyses, like everyone, like the data is also weirdly like more accessible. Like everyone owns their own data, but then it's it goes into a repository a lot easier. So you can do meta-analyses on like the entire country and like talk about like autism in Norway relatively. You've seen them all versus doing that
Right,
in the US. It's like insane. It's like no one does it.
right. Just hard to get the stuff.
Mhm. Yeah.
Right
And
on.
then I think I trailed off. There's more people at
No.
at Oslo. There's also the Ingunn Sandekar. She was the head of the program for a long time. She does cultural behavior analysis and like systems behavior analysis. And so that's a whole like field that I got out there, didn't know anything about. I still kind of don't know anything
Yeah,
about.
no.
But like a lot of people are doing from her lab are doing like healthy eating initiatives. And so they're working with the grocery stores and
Right.
things like one of my colleagues was, just moving the vegetables to the front or like doing like tweaks like that to see about like what that does for like the grocery stores in Norway for healthy eating. Yeah.
Cool.
And someone else, something with which
Good.
like they're doing cutting down truck idling in like Iceland for like truckers. So like
Wow.
teaching them to it's something like instead of like idling in your truck, just turning it off and then turning it back on for various reasons, health benefits, economic, saving the world, those kind of things. And like that was part of her paper. And so she's more in like OBM type of world,
That's awesome.
published that, and then yeah, so that their research is amazing. And then I think maybe one of the more famous people would be Eric Arneson,
Oh,
who
yeah.
does yeah.
So he's
Mhm. Yeah, so I'd be like those are like, and I'm missing people.
no, no, no,
like
but
like the OG people, like the people who potentially you would hear about. So I'm
no, I didn't
applying
realize
there.
they were all centered in one university. I've, heard all those names and just didn't know what was happening in Scandinavia, but it's all in Oslo.
It feels like it's all in Oslo. That's where like it seemed random, but when I started like kind of paying attention to like the people who were presenting internationally here,
Mm.
it's not always Oslo by any means, but it's just there's a lot of them there, and
Yeah,
they're all, at least if they're not from Oslo, they're friends with the people internationally. It seems like
right.
once you get kind of out of the US, like the Norwegians seem to be doing something out there in the ABA world.
Yeah, yeah. Right on, right on. So eventually I want to get to the Fragile X stuff, but where
Yeah.
does all the infant stuff fit in? When were you doing that work?
So when I started at with the early start was when I really started getting into like infant stuff.
Mm.
And so like the first study I was working on, they went up to the ripe old age of like 4. It's like 2 to 4, those really mature little guys. And then they did a second study while I was still there. That was like a study or something, but it was trying to go even younger. So then we were working with like 1 to 3 year olds. And so like working
Mm.
with a 1 year old was very like interesting. So it just kind of blew my mind being a younger therapist. I'm like, what do I do? How do they know what to
Yeah,
do when they come
yeah,
in for
yeah.
therapy? Like they don't know about like sitting and hanging out with you. Like, what
No,
am I
no.
supposed to do here? And then once I like, just got in there, I'm like, oh my God, but they're adorable. It's like they're
Hmm.
so cute. And so there are like, like some structural things you kind of have to put in place, but it's just really fascinating and really cute. And so I found it like really rewarding working with like the younger population. So like that was always something like I was like, okay, baby's very cute. Okay, I got to go get my
Hmm.
master's, got to do all this stuff. And then I think it was probably the first or second, well, probably first year of my master's, I saw Martha Pelaya's talk, and she did a presentation on like infant learning
Hmm.
and caregiver training, and that's another piece that I really like is like working with the infants and work caregiver training specifically. So I kind of stalked her at the conference and made friends with her, and then I've been working with her ever since, and we've been working really specifically just on caregiver training around like promoting joint attention skills, social referencing skills, early vocalizations, and working on ways that we can work on increasing eye contact too with really young little babes and their parents.
What does that even look like? Like I'm not a parent, and so
Yeah,
I've never really paid much attention to babies,
yeah.
so I probably wouldn't be a good caregiver in this study. But what, so maybe not what's that look like? Maybe start with what's the point of doing that kind of work?
Yeah. And so what we think is really interesting, what we haven't really been able to do too much like work into, because you kind of need like the larger studies. So like the studies that I'm on right now, I'm so interested in it because it is tracking early development. And you can see like when like early skills are showing, what like brain development, what that looks like, and comparing those trajectories for like kids who don't have older siblings with autism, those
Mm.
that do, and then also those who have Down syndrome, and just
Mm.
kind of seeing how they develop. What that study is really showing is, I mean, like a lot of people have some confusion around like when autism, like when a child is autistic, were they born autistic?
Hmm.
Wild stuff happened after they were born.
Right.
And what we're seeing in like the infant brain imaging study is like, I mean, sometimes by 6 months, like you can tell, and it's not again not like there's a genetic component to it. That's why we're
Mm.
looking for like the younger siblings of those with like who already have an like autism in the family. But it just I'm under the belief that it occurs at birth. Like it's something it's already there.
Mhm.
And so a lot of times parents aren't really looking for all the things that, could be, like the delays. And there's ranges, and there's ranges for very good reasons. There's so many people, like some people
Mhm.
walk at 6 months, some people walk at 15 months, and like
Right.
like pediatricians generally do a lot of interviews with all the families who are in the studies, and like they're talking about the diagnoses of their older child, and so many pediatricians are like, wait and see, don't
Mhm.
stress. And as a pediatrician, I'm sure you're getting parents freaking out about everything at all times forever, so that's probably a maybe okay thing for a pediatrician to say, but I don't think it is. There's like delays, and there's certain things where I'm feeling pretty strongly that like as a like an infant, like even if you're like a year old and you're not walking, and that's like a developmental milestone, by using ABA, you can probably start walking pretty quickly. Like there's just some pieces of like just little chubby legs, getting them like balanced up, getting them
Mm.
standing, and then like getting them in the positions and just doing some really basic, just like okay, if you're going through the motions, like does this help you walk? And
Mm.
probably. And so it kind of taking that concept with early vocalizations, and so like we're doing that like in the home. So like we're either coming to the family, or we're doing it through telehealth. And so
Mm.
initially we start in the home, we'd explain what we're doing, but with like the increasing vocalizations research we were doing, we would be comparing like what training the caregivers to try imitating their children. And
Mm.
so like kind of pulling out like any of the communications that are biological nature. So like not imitating burping, but like imitating cooing or babbling or just vocalizations. And so like we'd have a condition where we're teaching the caregiver like to be really attending to all of that and really copying anything they can. And then we'd be measuring what that does for that infant's vocalizations. Like, are they talking more under that? Then there's another condition that Martha got together called like Parentese or Motherese, where you're using more of like a like baby talk. And so like doing that contingent to like the infant's like babbling and seeing if that increases their vocalizations. And so kind of what we learned from that kind of research is like it's almost like the infants are going to prefer one or the other. But if you find what thing is going to increase those vocalizations, I think that's really important for like giving the caregiver those like tools to like, okay, your child isn't babbling, try imitating. That didn't work, try, Motherese. That didn't work, you can try rhythmic massage. So like, just like finding whatever kind of social consequence is going to be increasing those kind of behaviors, and then seeing what happens from there. So then you can start shaping it once like you have like more control over like the vocalizations, and you can move on to manding and labeling and all those things. But like I really like thinking about like that really early and minimal like intervention where like this is before people have an or have a diagnosis. Like that's why I'm so interested in like Norway. Like the diagnosis is like, let's just kind of think about like what's the delay, using behavior analysis to like fill those little like pieces, and using like caregiver training in a naturalistic setting, and specifically through telehealth has been pretty helpful for things like that. And so that's what I really like, and that's what I'm trying to. And if I can find an academic job, I'm looking to have like an infant operant behavior type of lab would be the goal.
Oh, wow, because that's sort of where you want to keep going then.
Yeah, because I think there's some people are doing it. A lot of people are doing it like 2 or older, and that's a little old. But like I want to work with a year-old. I like 6 months old is cool. Like we were doing some eye contact research as well, using contingent caregiver touch provided contingently when an infant like looks at their caregiver, and seeing like using like 1-minute trials where we're just hanging out with the baby. Essentially, the parent and the baby are like sitting like face to face, or the caregiver's like over the baby. And then if they look at them, then they like rub their feet and be like, such a little cute baby. And then like when they stop looking, then they just stop it. Right. And then when they look again, provide some sort of social reinforcement, see if that increases like the duration of eye contact, or like increases like smiles and eye contact and things like that, and seeing like, we can shape those kind of behaviors really naturally, really young, and in a really like, it feels like I've worked on eye contact not studies, but interventions with older kids, and like they can look weird and they can be funky, and especially these days there's a lot of ways you shouldn't be working on increasing eye contact, and like
you're not taking babies' heads and turning them, right?
It's not like that, and it's not like there's no like M&Ms, there's no like clicking, there's no like you gotta look at me for longer. It's just like when it naturally happens, providing a social consequence that should be reinforcing, and that's kind of the whole point. If it's not reward, it's not going to like increase the behavior. But it's specifically between the caregiver and like their child too, which is a lot different than like I got in there. I'm like, all right, baby, you want to look at me? Right. Probably not as much as like your caregiver, and it doesn't matter if we're increasing that. But like with your caregiver, I think it is really important.
And that must do a lot. And that must do a lot for the caregivers. There must be like a lot of social validity there, because they're, obviously if they're getting more looks and more babbles or whatever, mom likes that, right?
Yeah, and when we were doing those kind of interventions, where we generally start with what the caregiver is most concerned about. And then what we wanted to do was have it be kind of like a package that you could work through. And so the caregiver is really concerned about eye contact, or the caregiver is really concerned about vocalizations. Let's start there. And then what I'm the most interested in myself is like joint attention and social referencing, but those come a little bit later. Like I wouldn't and so like once we can kind of like, the individual can like make eye contact with their caregiver a little bit more reliably, or they're actually attending to their caregiver, then we can start thinking about like eye gaze shifting and like training different skills and more advanced skills. And the order doesn't always have to, it can kind of go in whatever. Like joint attention before social referencing makes sense, but like that could actually help, the acquisition of language. And so like you may want to do that before like you work on vocalizations, or maybe the caregiver is more concerned about increasing vocalizations. So start there and then worry about the other stuff after. But they can all kind of go together, and they're pretty quick, and they're in the caregiver's home, and it is providing skills for the caregiver. So it's not about the therapist knowing all this stuff. It's more of a collaboration between the therapist and the caregiver like knows the most about their child, so they're the ones who can bring in like, oh, I think they would like to sit here, or they, they're done today, or you can just keep it warm fuzzy feeling.
Totally, that's cool. So I assume most parents aren't, child psychologists and don't know a lot about sort of developmental stuff. I mean, I'm sure some get into that, but a lot of them don't have a clue. Like how do parents even know how do you get kids into these studies? Like how do parents even know their kids are not quick enough on some things? Yeah, I bet.
The hardest part. And so like I have not many papers on like the infant like training that I've done, because it's just been us finding younger siblings of families that we're already working with. And so like this is work I've done with like, Haley Naimi too. So like when she was just pretty much she's brilliant. She's like directing clinics all over the place. But like when she is doing in that kind of role, that we can find people who are already in her clinic and then are interested. But it's us approaching like moms essentially, and then sometimes we get, we'll hear from someone who's like, oh, they have like, a younger baby and they're like concerned. And that's always exciting. So we're like, yeah, usually it's more so us being like, you've got a child who's already receiving services, and I see you pregnant, or I see you have a 6-month-old. Are you concerned? Are you interested in working on research? Or, this is what we're doing. That's like, if you're interested, we'll give you more information, and then we move from there. But it is pretty hard to find infants, because especially infants at a higher likelihood of developing something.
So the key bit is that there is the siblings then. So these are most of these kids, they have an older sibling that's already had a diagnosis of some kind.
Yeah, and that's like, it doesn't mean that they're like the younger siblings going to have a diagnosis it's just a higher percentage than like the typical population. So like, sampling at random versus sampling, like you have like 30-40% is like like there's a higher likelihood that their younger sibling will have a diagnosis. And some of the families working with, like they have 3 or 4 kids, all of them have autism, or it's just 1 kid out of 5 has autism and the rest don't. But even in those situations, like with kind of working with the IVA study has been kind of, so it's longitudinal. They had a first cohort that was about 15 years ago, and now they keep getting more grants and following these kids, and so now they're moving on to like adolescents. And so for like these kids are moving into the adolescence, they've been following them since they were 6 months old, and they did behavioral assessments, they did MRIs, they did just a whole battery of assessments. 6 months old, 12 months old, 24 months old, sometimes 36, and then they came back at a school age point, and then they're coming back again at adolescence. And so you can see how these kids develop and how they either end up with a diagnosis or don't end up with a diagnosis, or they might end up with some other kind of neurodiversity. Now, there's just like some other profiles that kind of come into it where there may be some ADHD or like some other comorbidities that are coming out. And so it's fascinating, but generally I think you could be working on like just with anyone. That's again why Norway is so interesting. You could just, like working with anyone who has any sort of delay, like using behavior analysis, you can address those really quickly and really naturally. And like if you can find these families that may have issues.
And those are maybe this is a dumb question, but those are a lot easier to address when they're 6 months old versus 2 years old.
I think so. And so like with like when we're working on like joint attention, like I doing it in the way I like to do it, like remotely using telehealth in the caregiver's home, using the caregiver, you can teach joint attention skills in like a month. And like the sessions aren't that long. Like I'm also like working with like little young ones. They can't really attend for super long amount of time. Like at 6-month-old, like they can't even sit up. And so like it's, for the IVA study, I'll be doing assessments for roughly 2 hours, but they need breaks, they need diaper changes, they might need even a nap. I stopped for like 20 minutes and like, all right, I'm ready. Let's go back and finish it. But they need their sessions to be pretty short. So the sessions are like 40 minutes and like that's like with the caregiver. And then it's like 20 minutes with like the child. And so like these are really brief and it's quicker when you do it in this way versus like when you're working on promoting joint attention with like older kids that are maybe like 4 or 5, it's going to take longer. And then you have to worry about them running around more too the older they get. Like it's just kind of the more active they get. And so then that certainly becomes harder. Like I've worked with like older kids who are trying to get to attend to you and like do the gaze shifting and like they're out, they're moving, they're not even looking at you anymore. Like yeah, I think it's smoother and quicker if you can find.
Right. And so have some of these kids ended up getting diagnoses?
Well, and so with our study, we want to be able to follow them more, but a lot of the time, like we've kind of lost contact with some of them. And so I know some of them have, but yeah, like the idea is I want to do a randomized controlled design with this sort of thing. And so thinking about getting, I mean, for behavioral research and just like funding wise, like kind of would usually probably afford to get like 40 kids or something. And that's like the lowest you can have any kind of statistical power, but it's just like it's so expensive to do this kind of research. But you can have like 20 kids who receive the intervention and then like have like a lag for like the other ones who don't receive it yet and then like receive intervention, so you can compare those groups. And then I'd want to have follow-up points where you're just kind of tracking them for a little bit, for at least like a year or two, to see like the development of an autism diagnosis or not. But it's kind of, I feel like kind of secondary, like because what we're saying with like this kind of line of research isn't that it's going to like mean that you don't develop an autism diagnosis. Like I don't think that like necessarily like working on these things is going to mean you don't have autism, but it might increase like the learning opportunities that you have at a pivotal time, which means that like it might be easier to learn a language and might lessen some of the deficits later is kind of the hope. And so by learning how to talk and thinking about, you know, social referencing and those kind of nuances, getting those in earlier, what does that do to like later development in terms of like maybe you need less services or maybe you don't. Like when I started with like the ABA intervention, like that 1 year where I did my full like traditional ABA before I went back into working on the study, I was working with one kid who we were doing like an ESDM flavored intervention approach. It was in the Sacramento area, so people knew about that stuff. And it was like 2 and we're working for like 40 hours. And so one session on Fridays where I was there for 8 hours. You're like, it's barbaric now. And then like this was like a natural like play-based intervention, and like yeah it was, but like we're both tired.
Nobody wants to play for 8 hours either.
Like we had like real big breaks and then like I had like an hour break like in someone's neighborhood.
Yeah,
like, kind of like a weird place, so it's like literally in a car for like an hour, like here's my break, back in, ready to play. This family was so fun and lovely, and like he actually did, I mean I've followed that family, and like he's in high school now and like has a girlfriend and like all this stuff, like he's doing great. But it's still like I don't think you need 50 hours and like this kind of stuff. Like I would never, even like as a behavior analyst now, like working in Seattle, like we never like say like 40 hours. At University of Washington, I think because they were also affiliated with the Early Start studies, there was a study that was talking about like comparing like dosages, like do you need 40 hours, do you need 20 hours, what happens with 10 hours, and like they saw you didn't need 40 hours essentially, like around the 20 hour for even for someone who's needs a lot of assistance, a lot of support, probably be good. With these kind of interventions, like I'm talking about, even we haven't even seen like people daily, so it'd be like twice a week, 3 times a week for like 40 minutes.
Right. That's awesome.
Through telehealth, you just fit it into like your day, and it's a lot easier for the caregivers versus coming out to us or having us come to them too. That's a whole nother thing for some families too. Just opening their house and having like that's. And it's some families' homes, and they're like, some caregivers are like, oh, don't look at the mess. And it might be like the cleanest mess I've ever seen. But you just like have this like somebody's in your home, so now you have to act different in your home, and you don't really have that as much with telehealth because you can just you have your corner you're showing us.
Yeah.
have to worry about that.
Bit of a tangent. I don't know if the States has these folks, but I don't even know if everywhere has these folks. But up in BC, at least, we have folks that are in this that have this job called infant development consultants or supported child development. Basically, they work with babies doing stuff, and I don't know what they do, but do you have those kinds of folks down there? Like, it just seems like a good area for them because they're working on things like this, and they're looking at sort of developmental things, but it's not ABA. They're not like ABA trained. They're just sort of, kind of child development, eclectic sort of. You know what I'm saying?
Yeah, some states might, but like the fun part about the US is it's all like state dependent. And
Right.
so I know the most about the West Coast, and
Yeah.
like on the Fragile X study, I went across the US. So I heard a little bit more about how things were in like other states outside of just mainly California and Washington. Those are my main states I can talk about. But in California, and kind of in Washington too, I think they have a similar system where there's like a regional center or a birth to 3 provider. Kind of like the same thing. Where it's kind of hard to get into those services. So it's not something that like a lot of families really have to push for it. Some people are told that you can't have a diagnosis until like 2 or later. And so like they're just waiting to a certain point. And you age out at 3 from these services. And these services I don't think they're typically ABA based. In California, I think they are. In Washington, not as much. I think it's more so speech services, maybe OT, but essentially it is like access to somebody who has a developmental perspective who can then, but during COVID, it's all been remote. And so like these kind of services for like speech being remote has been challenging for some families. Talking too, because it's pretty much the caregiver has to be able to do it.
I guess what I was wondering more, maybe that was a kind of a roundabout way of asking, but are there folks that could be using this infant stuff? Like obviously parents can, and you can get that out to them and just say, hey, when you see your kids, babbling or doing whatever, looking at you, tickle them or whatever. Maybe that's all it is. But like has this stuff, maybe this is just early days for this stuff too, but has this stuff been kind of disseminated out so that parents or other folks could use this kind of stuff? Do you know what I mean?
That's part of what we're trying to do. So we're putting on like some workshops now where so far they've just been through like conferences. And so like it's predominantly been other practitioners or people who have an interest with working with infants. And so like the last one we did was a pretty intimate one, but there was 6 clinicians and most of them just like they had like a client who was younger and they're like, I don't know what to do with them. Like, what do I do? It usually, and there wasn't even ones that were like as young as like, I'm trying to get the like 1 or younger, but these were just like 2 to like 3-ish where they're like, what do I do with like this age? And so I think generally like in the US at least, it seems like that's where people are trying to like focus on like, what do we do with 2 and 3-year-olds? And I'm like, let's start earlier. But with like trying to get like I'm talking about in interviews for my academic positions I'm trying to secure, is like part of what I want to do is like put on like more community-based workshops where it is like more just caregiver or just opening it up to not just behavior analysts. I think it's always smooth with like behavior analysts because I'm just like talking about the procedures. I'm like, just do this procedure and do it with that family. Boom, go. And so it's a little different when you're just like opening it up to like complete caregivers and you're just like, you have to train a little differently. But I think I would love this to just be something that you can just package and give to caregivers who have a concern, like a handout type of thing, and that, like you just kind of get working with that and you start thinking about like, oh, like you can, increasing babbling, really important. That's fine. Or like if your kid isn't responding to their name, like, let's work on it. Let's like get them attending a little bit more so you can like, do that really naturally and early. Social referencing stuff would be harder to put into a flyer, but like trying to think about the pivotal skills that could be potentially delay or a deficit early and teaching people what that is, and then some like really quick or like little tips that can like address those is what I'm very interested in, because I haven't done work in like the gross motor development piece thing yet, but I've been doing a lot of like assessments on like infants, and there's certain pieces where like if they're not sitting up, then that's going to affect their eye gaze. So I want to kind of move into that piece too, where like working on like there's some like behavior analytic work around like tummy time and like those kind of things. But like, you know, I would, again, brainstorming, but like thinking about just like what are the pivotal pieces for like a 6-month-old or a 9-month-old or a year-old that they, if they had those pieces addressed, then like what other skills does that open them up to? So like, like, that's where the gross motor piece I keep kind of coming back to, where it's just like, I'm just working on sitting, just working on tummy time, working on like crawling. Tummy time is just for those who don't work with the babies all the time, like me, like a weirdo. Having the baby be like face down, essentially, I don't know, this isn't a good way to be face down, and then working on that like kind of pushing up piece. So like
Okay.
for the yogis in the room, but like the upward dog, that piece, and like getting that arm strength, but also that core strength. And so like infants can't really hold their head up, and that just reduces the visual stimuli you're going to be able to see. And that's just that some families don't know about like promoting tummy time. I think there's more of a generally it is something that people talk about. Pediatricians will talk about it too. So like it's something that's loosely going on. That if you don't know to put your baby on their tummy, then like they aren't going to necessarily start doing those, and then they might have a weaker neck, so then they might not be sitting up, their core may not be as strong, so then like maybe they're sleeping more. There's just like all these pieces that just kind of like you're limiting the learning opportunities.
Gotcha.
Like a small tweak.
I always want a question about motherese, some kind of baby talk or whatever. Why is that a thing? I mean, I know that wasn't really your research, but like, why do mothers do that? So like in your study, you sort of had, contingent imitation or non-contingent imitation, contingent motherese or non-contingent motherese. But like, why not just contingent, goo goo gaga baby, versus goo goo gaga, like, just regular old, I'm a clueless man talk, clueless mammies.
Well, we also we've shifted the terminology to Parentese to make it more gender inclusive, because it does not need to be just moms.
Yeah.
Usually when I do caregiver training, it's always moms. Like I'm never like just recruiting moms, and I always use the terminology caregiver. Like I'm trying to I'll take whoever.
Anyone
like 3 dads, and I've trained like hundreds of parents, but I've trained like 3 dads. But it's Parentese. And we have videos of like Jonathan Tarbox was on our study too, so he was doing our Parentese modeling for us, so we could use those. And like it's the same kind of concept. A lot of people do it naturally. I don't know why they do it. That's like do not know.
That's an anthropology thing or whatever.
Yeah, that's more the anthropology piece. But like I do know not everyone does it, and sometimes it's harder for some caregivers to do it. I was trying to train someone who it just wasn't in her wheelhouse. Like she would just talk to her kid like she was an adult.
Exactly. Yeah.
She's one of my friends, and so I've seen that baby grow and develop, and like she was fine, but like
Seems
initially, and this is when we were piling, and so like she just had a bit of a language delay, and so we're like, I don't know what to do. Let's get it. But I couldn't get the mom really to do this really rhythmic and oh, you're such a little cutie. I wish Haley was here. Haley can do it so good. She's Mothery's queen, and she's got that personality, her and Martha. That's why I let them present on those. I do eye contact. So again, I'm probably like it's a blind lead blind. I was trying and she just wasn't able to totally do it, so we tried to shift it around so it wasn't as much of a she wouldn't do that inflection type of stuff. She was just a little bit more she would do pet names and stuff, but it wasn't the rhythmic piece. And her daughter didn't end up speaking more in that condition. I think she did it more in the imitation piece. And so I think this kind of research, it's not so much about it's got to be motherese or it's got to be imitation or even contingent touch. It's just kind of figuring out what that individual likes or what actually increases that for them, and then giving them that. And then also kind of working with the caregiver. So if the caregiver isn't someone who can develop that kind of repertoire, then finding something else that would work for that child too.
Seeing, gotcha. Okay, so you did a bunch of this child stuff and infant stuff, and that's kind of what you want to do going forward. But in between, we got this sort of Fragile X thing. How'd you switch over to that? Why'd you switch over to that? The second secret word is Norway.
And so it was a research job, and they were going to pay me, and it was Stanford. So I was like, heck yeah, that is. And for that study, I mean, because I had telehealth research was why I was a good candidate for that. And so the rest we decided to train me once I was out there. Not having experience in Fragile X is pretty common because it is, it's one of the more it's one of the more common inheritable genetic disease or causes of developmental disability, but it's still really rare. And so being able to work with, I'd worked with like one person with Fragile X before I came in, and I was like, oh, that was enough, because it's a lot of people just don't end up working with a lot of people with Fragile X. Just they're spread out. It's not a matter of, like it's hard to find a location that's going to be like appropriate to see a lot of people with Fragile X. So there's centers, and Mind Institute's definitely one where people will travel like from Texas to come to like the Mind Institute just to get an evaluation from somebody who knows Fragile X specifically, versus a lot of people just get a blood test and then they're like, yeah, you're Fragile X. And they're like, what's that mean? They're like, I don't know. So similar. So when I came in for that position, I was just excited to get a job at Stanford that was in research and in ABA. And so I had to learn more about like functional analyses and more about Fragile X, like very specifically, because that was the population I was going to be working with. But that's kind of like another big piece of my eye-opening experience around like diagnoses. It doesn't totally matter for like the application of like ABA. There's like certainly some things that are going to be like more effective with like with certain diagnoses, and like certain things that might be like more uncomfortable or less uncomfortable, just like certain tweaks you're going to have to make for different populations. But like essentially the whole study was just using like things that have already been done with like ABA with Fragile X, and for like insurance coverage, that's important. It's important to show like, no, specifically you can't deny this person coverage because like they, the ABA works for Fragile X as well. But especially like recruiting and going to like the Fragile X conferences, everyone's like, they would say like the A in ABA isn't for autism, it's also for like, you can also work with like other populations, like, but a lot of people, like I was recruiting for that, and I just kind of cold call people who had reached out to like our survey, so like that's how I had their phone number. But they didn't really, a lot of them didn't know anything about ABA, or they'd heard like bad things about ABA, which do. And so you had to kind of like work through that and really describe what it was. So I kind of like stumbled into that one as well, but just not many people are working, like not many behavior analysts really are working.
Did you have anybody with Fragile X in any of your infant studies?
Yeah, so since I had those populations, then I started using the same inclusion criteria of like, they did have to have like an older sibling with autism, but then I had a couple participants who had Fragile X, just because those were the kids that I brought to the table in terms of like who I could recruit from.
Yeah. And what is Fragile X? I know a little bit about it. I mean, the X is the X chromosome, but that's about it.
Yeah, no, and that's like any talk I gave on my studies, I'd have to like spend like minutes trying to describe what Fragile X was, just so people knew what like what Fragile X. I'm like, the X-Men, like, was this a superpower? Like, not really. So like essentially, like, it's kind of in the name, like the X chromosome is fragile. There's proteins that are missing from that X chromosome that make it kind of a little sad looking. And so when you so it's X chromosome related, it I was, for my study, we were only working with boys who had Fragile X, because it's more boys with Fragile X are more severely impacted because they only have that one X chromosome. Females have the two X chromosomes, which means just your genetic material is pulling from either one of those X's. So you could be pulling from the affected X or the non-affected X, and it just generally presents with like a less severe impact, where you may be able to live independently or hold a job, or maybe you can't. But so we only saw boys, and then the deletion of the FMR1 protein results in just like a cascade of neurodevelopmental issues, where like communication issues, like some learning disabilities, could be some differences, some like slight physical differences. Like not everyone has the same characteristics, but there could be larger ears is kind of a common thing that like a lot of parents talk about, like, oh, he looks like he has Fragile X, he's got the giant ears. And some of them have really great hearing. It kind of came up when we gave the parents Bluetooth like earphones, kind of similar to this, but it's fancy. And some kids could hear me like whispering to the parent, like, okay,
Wow.
and then they'd be like, no, like we would be texting one mom because like we couldn't even
Yeah.
like we little guy was just like,
Yeah. And hearing
this
it
every
coming
time
out of the headphone. Wow.
out of the headphones. So like, I mean, not everyone has increased like hearing, but there's some things like that. But it does kind of look very similar to autism if you don't know. And so like autism is a behavioral diagnosis, like Fragile X, you can get a diagnosis in utero. Like it could, it's dangerous, so not everyone does that, but it's a blood test. And so like you can have a diagnosis as soon as you're born, essentially, like, or before birth. So I worked with some, like one mom, she had twins, and we couldn't accept her genetic test because it just said like twin A and twin B. And it was like, that could be anyone. Like,
Right, right.
so we had to wait till they had like a more specific one that actually had a name, but because they like had received the diagnosis so early, like they didn't have like their child's name on the genetic test, which seems a little weird too, but it's Florida. And so and then there's you can be a carrier, or you can have full mutation, or you can be mosaic. And so all the moms in our study were carriers, because to pass on an X chromosome to a male, you have to be a female. The dad's passing on the Y. And so like all the moms were carriers. There's health issues associated with that too, like not necessarily like a lot of the caregivers were highly educated, worked jobs, like there weren't any like obvious signs, but you can go through early menopause. And so like by 30 or like you could be going through menopause at like 30. And so like it's super early. And if you just don't know if you didn't know you were a carrier, which a lot of parents don't know, they find essentially like the child gets the diagnosis because of learning issues in school, and then the like diagnosis kind of moves up through the family, because then if it was a boy, then the doctor's like, probably came from mom, and so mom does like a test, and she's like, oh, I actually have these repeats. And so like on the blood test, it tells you how many deletions of this protein you have, the FMR1 protein. And so if you have from 1 to 199, you're a carrier. It means like you don't have full Fragile X, but it means like you can pass it on. If you have 200 or more, then you have Fragile X. You could also be mosaic, and that means you have two different numbers that are coming up, and that kind of confuses me for the boys. I don't know where. Some of the genetic reports I'd get had two numbers, and so it'd be one that'd be like 128 and one that's like 1,000. And as long as they were over 200 on one of those numbers, they had Fragile X, full mutation, and we moved on with our study. But it gets really complicated with those like duplicates and those numbers, because they've kind of stopped even they'll just say like over 200, because there's some like confusion or debate around like, does having more deletions mean like you're more severely impacted, or does it mean something, or does it not? And it seems kind of hard to pin it down. Like one of our first participants had like over 1,000 deletions, and like he was someone who could hear us, but he was doing pretty well. Like he would talk about like having a girlfriend, and he would like pretend to call her during like he had like a lot of great skills. So it wasn't compared to like I worked with someone who had closer to 200 and was nonverbal, like didn't have a communication system in place. And so like I think it just kind of became confusing with the deletions. So just essentially the important part is 200 or more, you have Fragile X. Under 200, you're a carrier. And for like men who have it, I think, or as carriers, I think it's men or just generally carriers. But then there's something that's developing that looks kind of like Parkinson's when you get older, where there's tremors. And like, so there's just like a lot of like extra health issues associated with it. But generally, a lot of people, if you didn't know or your family wasn't aware of this kind of thing, like you'll just get a diagnosis through school, and they might say like, oh, it's autism. And then you're like, is it autism? And then you might end up with like 2 diagnoses. But generally, it does present very similar to autism. So like a lot of the ABA strategies just work very well with them.
And these folks with Fragile X can get an autism diagnosis too, right?
Yeah, and it's kind of a funky place where you don't receive coverage in the US if you have Fragile X. Like you'll receive what is provided through school. You can have speech, you can have OT, depending on where you're at. That could be it. So I was working with one who was like 7 or 8, in a Midwest state. They were like working on reading with him, and he didn't have a communication system in place. So like at school, like they were going through, sentence comprehension for like a poor guy who like didn't even like we were working with like text to kind of teach him like just like how to mand. Like that was kind of like the base level of like how to even like his mom was just trying to figure out like if he could tell me like what he wants to eat, like man, that'd be so cool. And they're working on like sentence comprehension at school. Just like didn't know what they were doing out there. There was no ABA available, or I mean, like when after we stopped working with them, we were trying to get them set up with like some practitioner for when we're gone, and like the closest practitioner was like 2 hours away, and that was the closest practitioner for like ABA, and so that's out of pocket for anyone who has a Fragile X diagnosis. It's really hard to have anything be covered, and so there is a higher proportion of people with Fragile X who have autism, but my boss at Stanford, Scott Hall, would say that, like, do they have autism or do they just have Fragile X? Like a lot of the umbrella, like behavioral issues for like autism, those could just be Fragile X. Like the language issues, like there can still be stereotypic behavior. There can be social differences as well, but there's like some nuances to it. So when I had people who had Fragile X and only a Fragile X diagnosis, I would recommend that they still got evaluated for an autism diagnosis, for the main reason of like you can receive services if you have the autism diagnosis. And so like for certain families where they're not too concerned about labeling, that just opens up so much access to like insurance provided intervention that they wouldn't have under the one diagnosis by itself.
So I don't understand. So the Scott fellow was saying, do they have autism or are they just Fragile X? But can't they be both?
They could be both. And it kind of, I think his perspective more so was like this one label covers all of those pieces. Like there can
autism is a behavioral diagnosis, right? There's no blood test, or no genetic testing or whatever. I mean, if there is one day, that may change everything. But right now, it's they do these things and we say they're autistic. So just because people with Fragile X also do these things, doesn't that mean they're also autistic? Like, shouldn't all Fragile X folks then be autistic? I mean, it's weird. You know what I mean? It's weird.
It is weird, and that's where it kind of hurts my head when I it's like it, but it's not an either or type of thing, and so that's and a lot of people end up like I think that's where like the issue is. It's not like everyone has Fragile X and autism, or like no one has, like there's a lot of people in between, and so like I think his argument is more around like it's the people in between, like are those people in between really different from the people who just have Fragile X, or is it a misdiagnosis? And it's because autism's a behavioral diagnosis, it doesn't really feel like there's a way to really like tease that apart. But I mean, to your point of like if they're doing those behaviors, do they have autism? And from like a purely diagnostic standpoint, like yes,
they do.
But is that I don't know. It's an interesting question. Like on the IBIS study, we're also following kids who have Down syndrome and like evaluating them specifically for autism. And because that also is another disorder that has like a highly comorbidity between the two. Really not finding as like when it comes to like a language delay, like it looks so different from like the kids who have Down syndrome look just so different from like the ones who like have autism. And it kind of, I don't know if it totally matters. Like with the Fragile X, like if they have that dual diagnosis, I mean, I was of the opinion of like sending parents to like check it out. Just like, I can't diagnose. All I can do is just, like tell you with some things to check out. And so I'd tell them to check it out because I know that they would get services if they qualified for that diagnosis. And so that's kind of what I care about. But then when when you pull it out into like kind of meta-analysis of like the numbers of everything, it's kind of skewing things. And even with like children receiving an autism diagnosis here, like I think there are some times where people are being overdiagnosed just because like that's the one that gets you services. And so like if there's just an ambiguous language delay, having an autism label means that like now you can access a lot more services than you would if you just had a speech delay. Such a mess.
It is a mess, and I mean, it also, It's a mess. Look at what maybe let's just go right into the dissertation, because I mean you did a few studies sort of before that, but they were all, I think, part of it. They all came from the same sample or whatever. So what was the RCT all about?
Yeah. And so for that one, and so that's, yeah, like that study kind of covers everything. And then the other studies were just kind of describing the pieces of it. So like one was about the assessment and one was about the training, but like the RTC was like the main one that covers all of it.
Yeah.
And so we enrolled anyone who had a son who met the criteria in terms of being full mutation, meeting the age requirement. I lowered it when I was there because I was like, let's get the babies, let's get them as young as possible. So I think initially it was like 5 to 10, and then we kept it. I was like, what about 4? What about 3? I think we got down to like 2 by the end. I was like, let's get them all. So and then so we took anyone who had the at least 200 repeats. They needed to be willing to do the ABA intervention. They needed to have like the ability to like have some internet in their home. Like we were initially thinking we could provide some internet. Like we had like a Wi-Fi enabled like iPad that we could give to like someone if needed, and we had Wi-Fi extenders, but you did have to have like a certain base level of internet. We didn't exclude anyone for that, but they had to meet the inclusion requirements, and then we randomized them. And so like everyone had to want and be available to do the caregiver training. Oh, and their child also had to have some form of behavior like aggression, self-injury, property destruction that was occurring regularly. So at least weekly. I kind of, depending on what it was. A lot of them, some were hourly, some were daily, some were weekly. So they had to have that level of a challenging behavior, and then we randomized them. And so that was my least favorite part of the study, was that conversation where I recruit them, and then I have to say, okay, 50% of you are going to be training, 50% of you are going to be observation. And so the observation is kind of this treatment as usual, which with ABA not being covered meant pretty much just observation.
Yeah.
And so then there were surveys that we sent out at different time points. So like kind of the baseline, the first week, 4th week, 8th week, 12th week, and then we had a 1-month follow-up period where we weren't meeting with them anymore, but we're still sending out the surveys and then checking in at the end. And so it was loosely the process. And then for the families that were randomized into the training side of things, flew out to do functional analyses at their house. So with them at their house. So I coached the caregiver through that. I didn't train them on that piece. It was just live coaching for that piece. And then I flew back, analyzed the data, get a report together, develop some hypotheses around the function of some of these behaviors like aggression. And then we'd do a pretty brief training, just a kind of loose general functional communication training. Like this is prompting, these are communication cards, this is modeling, this is, these sort of things. And then after I flew back and we gave them the report, everything else was remote, and we meet over Zoom like this. I gave them like an iPad, case, earbuds, manual, communication cards. All of the functional communication we were doing was with the kind of modified PEX icons. We kind of made them a little bit bigger. And then we started with a thicker schedule of meetings, and then based on the caregiver's fidelity and the reduction in the child's challenging behavior, we started fading out our sessions, so that we started with 5 days a week and then went down to 1 or 2 days a week towards the end, kind of based on how they were doing.
Did the folks in the observation group, did they later get stuff, or?
No, is not a structure I would do moving forward, because it just felt I had to be the one to tell him that, and that doesn't feel great. And just like everyone was, most of the people who wanted to be in the study were kind of desperate. They were in places without services, and they're like, this sounds insane, but yeah, you can come out and do this if it means like you can fix this. Like if you can fix this, yeah, you can come out and do this crazy stuff. And so like I got them willing to do this, and then for half of them I had to be like, thank you for your contribution to science.
Oh, that's hard.
don't like that part about randomized controlled trial. And I think a lot
No.
of people in ABA don't, but there's ways to get around it. Like it's a funding thing. So like for this study, it was, I didn't secure the grant for it. Dr. Scott Hall did. Good
Yeah.
for him. But it was like $5 million, and we only saw like, or like we ended up seeing like 60, 70 or so. We recruit a lot more. Some like, didn't want to be like totally fair to say no to this.
Yeah.
And like, we lost a few people throughout the course of the study, but it's 5 million just to do this, just to do like this front and like just to see like really like we ended up seeing 30 or 40 kids where I actually flew out and did that. And so like it was that much for those kids. So to think about how we would have like, oh, and then we'll just see the other ones. Like that's another like 3-4.
Right.
And so like he did get extra funding, but like how the extension grants work, like it was just kind of a follow-up grant. And so it was only like, I don't know how much he got for that, but essentially we just followed everyone that we'd already seen. And so we like got follow-up points on, the people who had received intervention, the people who hadn't, just to see how things had maintained. But still, even so, that was a decent chunk of money, and it wasn't enough to cover like actually seeing, the control family. So that's something I want to build in, but it also then reduces the amount of people you can see. And so that's kind of what I was saying earlier with like, hey, I'm not shooting for 40. I'm just trying to be realistic around like even shooting for 40, like doing intervention. We had a small team. We had like, there was Scott, there was me, we had a collaboration with a telehealth agency. So we had Joy Pollard, who's lovely in the telehealth world, and one of her employees, Arlette Luhanda, who is a behavior analyst too. And so it was a small team. It was just me and Arlette who were really doing like the caregiver training and like the content. But still, it would like, it was ran through that money relatively.
Where did 5 million go?
Well, the fun part about research is the institution takes out a chunk of it. And so like just by having the honor of working at Stanford, you got to pay for that. And so there's a big old chunk goes for that. And then another big old chunk goes for benefits. Like benefits are super expensive, and like for like paying salaries eats that up pretty quickly. And so I know a lot of that went for that. I traveled out, and so each one of those trips, like it was only like a weekend, and this is pre-COVID. So like I don't even know, like it would have been even worse now. Like on the study I'm working on now, we fly families out, and like it feels like those trips I've like doubled. Like the flight and the hotel have gone up pretty substantially. So when I was doing it, it was something around like 1,000 to like 1,500 probably per trip. But then that
adds up, 40 kids.
Yeah, no, then that's just 50,000 roughly just to see those kids. And that's not the time of like my time training them later. So then you have to think about that salary and that, benefit.
Wow.
Trying to think about applying for grants and getting grants myself and thinking about like, and then who do I pay? Who can I like, I want to like make sure that it's fair. And like, we gave them like a little bit, we gave the families like $200 or something for participating. Like it usually went to the child who would then spent it on an iPad or something. They're so expensive. It's just insanely expensive to do this kind of research. And so like with the infant stuff, we've just been self-funding it. Save up for cameras and then iPads and then donate our time or whatever. It's like, we're not paying ourselves here, but it's so expensive. And so like that was really the piece of why we didn't see the other families, but it just feels so terrible that I would really try not to embark on something like that again without building that in. But potentially it was just, the funding piece of it.
Yeah. So what'd you find out?
We found out that surprise, it works. Like very similar to like the research for like the kids with autism who go through like a telehealth functional communication training program. Like Dave Wacker at like Iowa, I think he retired or something, but he's huge in the telehealth research. And he has randomized controlled trials as well, and like meta-analysis of like the research work he's done, and he's showing roughly 90% reduction in behaviors like aggression and self-injury. And that's what we found for our families. Like for some, we found like even, it ranges like 78 to like 98% roughly. So like roughly between like 80, 90% reduction in challenging behavior. And this was like a very brief intervention, like because Fragile X is like a genetic disorder, a lot of the funding sources are for pharmacological interventions. So we kind of based our timeline just around what a pharmacological intervention would be. So that's why we did 12 weeks. It was really just to get that money, but not because we're like, oh, 12 weeks, that's the appropriate amount of time.
Right.
So that was another annoying piece about this where, like it'd be cool to just do it based on like how long it actually takes to get a challenging behavior down to a 90% reduction. But that's not what we had. We worked within those confines. But we found like within a pretty brief intervention where we counted the amount of hours some of these families got, and they were like about 40 hours roughly. And so it took about 40 hours across like 3 months, and we were able to show like 80 to 90% reduction in challenging behavior with Fragile X. And so a lot of people, when I would present at like some conferences, they're like, oh, maybe it doesn't work for Fragile X. And they're like, well, this does. Fragile X. Or like functional communication training is like a pretty big cornerstone of ABA, and it sure does work. And there's, so that was cool.
I don't think you were surprised. I mean,
no, that's why we were doing it. Like, and when I was recruiting people, that was like another piece where I was like, Bertie, like this is stuff that works with like these, with like so many different kids, and like autism is such a big spectrum of like ranges of abilities and skills that like if it works with them, like I think it's going to work with this population too.
Yeah. Obviously, it's still not covered by insurance. Is this just sort of one step towards that? Like, how does that work in the States? I mean, obviously, it's going to vary on state, it's going to vary on insurance company, and so on and so forth. But just sort of, generally speaking, what's it take for insurance to cover something for anything?
I think it's like legislation, and that's where like it gets like so confusing because I really just don't like the insurance in general. And having the experience where I've like worked in research where I hate having to charge families. It just feels terrible.
Yeah,
like
for sure.
I worked clinically the last couple of years, and it just felt insane, like having to like charge families for this. And like obviously you got to get paid, but it just like it feels so icky odd when you're like, especially if you're just like being a behavior analyst in someone's home, like you're sitting in there like talking with the caregiver from time to time, and sometimes you hear about the financial complications of things. It's just so icky. So anything I found out about insurance I kind of shut down around, because it's just like burn it down, like it's terrible. But I think it's a matter of like you have to have so many studies that have been published that meet a certain level of criteria that means like, okay, now we can start covering that. And so that's why the randomized controlled trial was so important, because like to a lot of psychology or just a lot of the medical field, that's the only way that you can really show efficacy. So that was the important piece of what we're trying to do with like the control trial. But you need to have like so many different studies with like different institutions. So like us having, like a few in a series, kind of like the idea is like, yeah, that's the same kids. Like we need someone else to validate that. Like, come on, we need somebody else in here. We need new blood. But that means somebody else has to go through and do a randomized control trial and like show efficacy. So it's actually going to be a process. And then I think it's probably a matter of legislation and like families who are just pushing harder than they should have to and petitioning, and then there's some change. But I don't know the full process because it's really sad. I haven't wanted to learn to just get more sad.
No, for sure. And me being in Canada, I just happy I don't have to think about any of that. But at the same time, we're not getting covered for that either. So it's I'm curious sort of what. So are you you're looking to do more sort of going forward? You're looking to do more of this infant stuff. Are you gonna do any more of the Fragile X stuff too, or?
I keep doing it as well. Like I think especially at this point, because I've talked to so many families who have worked closely with like 30-40 people who have Fragile X, that puts me like I have more experience with Fragile X than a lot of people do. And so like I don't want to like, it's not like I'm trying to, I just want to like open it up so it's not so like diagnoses specific. Like that's a more interesting place for me to be in. But yeah, working with Fragile X specifically because just people don't know much about it. And the same with, I really like the infants and the early operant learning and the pivotal social skills. but then so many people need help with like, like aggressive behaviors. Like those, that's such like an important thing. And like, especially in like just what I've been looking for, the academic positions, and like certain places you get to like locations where like they don't have like the infrastructure to even have like a functional analysis. And like a lot of people don't do them in home, or like or maybe a location doesn't have like a clinical room to do a functional analysis outside of the home. So then people just aren't doing functional analyses there. Only way to get, address challenging behavior, but like it's the most effective way to do it. And so like I ended up like when I was working clinically in Seattle, I was just like, babies, that's what I want to work with. That's why I'm here. And then I kept getting like the kids who were older who had challenging behavior because like no one else had like worked with that. And so I think I'm not going to like get away from it. I see the importance of it. And I've been trying to find ways that tie everything together. And it's still like, I like working with, coaching caregivers like through telehealth on pivotal social skills. And that's what functional communication training is. And so it's just, a different pivotal social skill at that point, and thinking more specifically about function matched communication. But it's loosely the same thing. And so like some interesting areas for me are thinking about like when some challenging behavior starts, like, and addressing it at that point. Like 2-year-olds, and I mean, it's like you can be showing like aggression and self-injury pretty young. Like some of the kids I was working with were like 2 or younger when they were like hitting their heads against like the ground or hand biting. They were doing that really young. And so thinking about like, what happens if you intervene on it at that age? Like if, is it even quicker? I imagine it would be, and imagine it kind of circumvents, a later, larger frequency of that kind of behavior, which has its own health issues. So that would be interesting.
Yeah.
And you're going into like, joint attention social referencing with like kids with Fragile X. I'd be very interested in doing that too. It's just a matter of you become limited financially because like, unless you can pay $5 million US, like the family's going to have to come to you.
The third secret word is research, or do it all by telehealth or something.
Yeah. And there's like, I think, I was, especially with the Fragile X population, we didn't want to do a remote coached functional analyses because it just seemed a lot of variables. Like already, like we knew like telehealth would be like probably be fine, but like it was still like this was before COVID, and so everyone like we knew that, but then like a lot of people were like, but would it?
Yeah.
But what like Dave Wacker's doing, like they weren't flying out to do the functional analyses in person, and her name is so cool though. It's like Sami, Rukia Sami. Oh, cool.
Yeah.
She's so cool. And she also doesn't fly out and do like, the functional analyses. She just coaches them. And we met after I saw her presentation. And she had, some scary stories about like, and then like the kid knocked the mom out for a moment, and then she called us back later, and like, oh my God. And like being like a country or two away, like, terrifying, but like also if there's no other, like if no one else is going to help you in that like country, people are going to roll the dice a little bit with that. So like you kind of like got to get over your own uncomfort in that to provide like important services. And so like I really think that's like amazing. Like I want to copy what she's doing with like international stuff. Like I think that's so cool. And you don't have to fly out and do it in person. So like I think especially like knowing that, I just have to get over my own like it's just I maybe I'm just like neurotic myself, but like I have so much comfort around like I know what that house looks like now. Like I've been there. Like they don't have to show me the whole house, but like we walked through the parts of the house they were willing to show me, and we found the like location that I thought was going to be the best in terms of like just like more controlled entrances and exits. Like if it's an open concept living room and the kids can run to the kitchen, you're like, oh no, this isn't the best like location. But going out and seeing everything, you just like have a better understanding of like, hey, you had that chair in the hall. Can you go bring that in? Or
nice, yeah.
You're next to the bathroom. Go get a towel. But you don't need that. So I have to get over my own thing on that and just get in there.
Gotcha. Well, if you can score a good position, maybe you can get some grad students do that for you too, right?
And that's where I'm like so interested in moving into like that side of things. I've been like over I was kind of going like the postdoc route here, and kind of thinking like the funding, it's just so mean. It's just so intense. You have to completely fund your own position. I didn't like, I've been working research for so long, but it just like I was working on, the lower side of things, not on the top end.
You were funded by others, sort of thing. So yeah.
And then now just kind of realizing like, okay, just the general postdoc scheme is like you're there for a year, you get a job or you get a grant so that you can pay for your own position. So you've bought out your time now. And that doesn't mean like, oh, you have money to do other stuff. That just means you bought out your time. Now you're free to like get another grant to do like your research there. And it's just like this like rat race of like, you can be, like I knew people at Stanford who were like, full professors who got, had to go on forced sabbatical because they didn't find more funding. And it's just like insane that like that's your professor job. But if it's predominantly research based, you're inevitably going to have these like ebbs and flows where like, yeah, you had to like get hired by this institution, but like they're not going to pay for you for like your whole position. So that's why I'm looking for more like professor positions just to kind of like buffer that a bit where
for sure.
You have to like teach a lot. I like teaching, but it means that you're not probably going to go on forced academics.
Gotcha. There's a backup there. Yeah. Cool. All right. Wow. Super awesome, Kat. Well, really interesting. I'm looking forward to when you get a new gig so we can see what you're doing next.
Me too.
Yeah, for sure. Well, if folks are listening, Kat's looking. Yeah. Although, fingers crossed, you're working by the time this comes out. Yeah. And thanks for coming on.
Thank you. Thanks for having me.
Cheers. If you enjoyed this conversation, check out these episodes on similar topics. Episode 199, Behavior Analysis and Prader-Willi Syndrome with Dr. Casey Bedard. Episode 6, Behavior Analysis and Down Syndrome with Dr. Nicole Neal. And Episode 16, Pediatric Behavior Analysis with Dr. Amy Tanner. If you enjoyed this episode, please consider leaving a review on Apple Podcasts, Spotify, or wherever you get your podcasts. And please follow us on Instagram @BehaviorSpeak.